David Liew here from Melbourne, Australia, reporting for Room Now from the end of the first full day of the conference, of the main program of the conference. There's been plenty talked about in the rheumatoid arthritis space, but I want to just highlight something which is perhaps a little bit neglected. Neglected probably is the right word, and certainly isn't talked about as much as we'd like, and probably not talked about because it's one of those things that we all dread and we can't do much about, and that's fatigue. We know fatigue is common in patients with rheumatoid arthritis and other inflammatory rheumatic diseases. We know it's a big issue and has a massive impact on them and really gets in the way of them achieving the functional goals that they want and us achieving the targets we want for our patients. And at the same time, we know that we've got no meds that really are proven to do any benefit there, and that maybe if there is some benefit from non-pharmacological treatments, we don't necessarily have easy access to them. So all of that in mind, really fatigue something where we need to do a lot more work on. Now, that's the context for abstract 0462 from the oral abstracts today, the LIFT study, which was presented by Neil Basu and involved colleagues from across the UK there. It was a pragmatic randomized control trial looking at what we could do about fatigue for inflammatory rheumatic disease patients, primarily overwhelmingly rheumatoid arthritis patients, but a few others scattered in there. So what did it do? And it was in the context of COVID, and everything's in the context of COVID, but it was remote delivery of there were three arms: remote delivery of cognitive behavioral therapy, exercise program, or usual care, and compared the three. So this was adults with stable inflammatory rheumatic disease and over 3 months of severe and persisting fatigue. And what we saw is that 1 year, both the CBT and the exercise program led to clinically significant improvements in fatigue severity, in fatigue impact, and global impact outcomes. And that's with a limited number of sessions, up to 8 sessions, and most patients had less than that. So to get those kind of real benefits, if we saw those benefits with a medicine, we'd be thinking about registering this. I think we need to try and weaponize our non-pharmacological therapies to try and do something for our patients and their fatigue. And there's a lot to actually figure out in terms of the details, in terms of how many sessions are really needed for the exercise program, which really did involve targets and behavioral intervention, how much of the CBT is needed, and that's a lot about trying to teach people problem solving and behavioral experimentation and cognitive restructuring. It's not clear how the two of them interact, of course, as well. But I'm really glad to see this work has been done. The authors are going to be publishing some of the details on their website. So hopefully this is the kind of thing that we can roll out right across the world. How we can access this will be the next question, but we need to do something about our patients and their fatigue. For plenty more about rheumatoid arthritis and ACR in general, head on down to Room Now and check out all the great content.